My name is Dr. Ahmed Ibrahim. I am a retina consultant in Maghrabi Eye Hospitals and Centers in Jeddah, Saudi Arabia. Our presentation today will be, we will discuss a very important issue because very big numbers of cataract surgery in the world now, which is posterior segment complications of cataract surgery. I will divide it to two parts because it's too long to mention in one part. In part one, we will speak about pseudophakic retinal detachment, dislocated IOL, and pseudophakic cystoid macular edema. Next time, in part two, we'll speak about dropped lens fragments and endophthalmitis. Our first talk is intraocular lens dislocation. Intraocular lens dislocation has been reported to occur in 0.2% to 3% of the patients after cataract surgery. The incidence may increasing because of widespread of phaco in which IOL can be implanted in the preserved peripheral anterior capsule caused by capsulorhexis. What types of intraocular lens dislocation? There is a partially dislocated, complete dislocation, in the bag dislocation, which is more common and occur late. Out of the bag dislocation, it's less common and occur early. And dislocation of the IOL with a capsular tension ring with the whole bag, which we told whole compartment dislocation. What is the anatomic site of dislocation? Typically inferior. However, anterior dislocation into the anterior chamber, which is rare, but it happens, and superior dislocation can be seen. Predisposing factors of dislocated IOL. Number one, in the bag IOL dislocation. It occurs late, maybe years after cataract surgery. The predisposing factor is pseudoexfoliation in 50% of cases, previous vitrectomy, 20% of patients, uveitis, 2 to 15% of patients, trauma in 5% of patients, and retinitis pigmentosa, slightly rare. What is the cause? The cause is weak zenules plus capsular fibrosis. The out of the bag IOL dislocation, it occurs early and less common than in the bag dislocation. It's typically follow failure of insertion of IOL in the bag due to posterior capsular tear and secondary IOL insertion. It's very common in the complicated cataract surgery. Complications of partial dislocation. Number one, visual symptoms in the form of blurred vision, diplopia, perception of IOL in edge, complete dislocation after, one of the most common complication of partial dislocation to be completely dislocated in the vitreous. And it's very rare to be anteriorly dislocated, especially only with trauma can be. Pigment dispersion and anterior uveitis and cystoid macular edema, also very common complications of partial dislocation of IOL. What's the complications of complete dislocation? Usually posterior dislocation and the most commonly inferior. Visual symptoms, blurred vision and diplopia, vitreous hemorrhage, retinal detachment, retinal trauma, especially in vitrectomized eyes, and spontaneous reposition, but it's very rare. Dislocation of the intraocular lens, capsular tension ring, and the bag, which named as a whole compartment dislocation. It is the same complication of total dislocation. The capsular tension ring was found to provide a stabilization for capsular bag and IOL after cataract surgery, especially in pseudoexfoliation patients. The most common cases for the capsular tension ring uses pseudoexfoliation. That's why some studies advised for a routine use of capsular tension ring in a patient with pseudoexfoliation. It's common and occurs late, especially if the zonule is very weak and unstable. What is the management of IOL dislocation? Number one, observation. When we will observe a dislocated IOL, especially if the patient has no or mild acceptable visual symptoms, the IOL is partially dislocated and stable, not freely mobile, which decrease the risk of retinal complications. patient can tolerate, and the contact lens, if totally dislocated, he can tolerate the contact lens for vision. What's the advantage of observation? No surgical interference. This is the only advantage. The disadvantage is still risk of retinal complications, contact lens problems with the patient. The second line of management of dislocated IOL is implantation of secondary IOL without removing the dislocated IOL. What is the advantage? Correction of aphakia and visual symptoms. The disadvantage, risk of complications remains. Risk of dislocation of the secondary IOL also. More challenge surgery if it happened and second IOL dislocated, or the patient have a retinal detachment or any problem needs vitrectomy, is a very challenging surgery in the management of this. And for me, I didn't recommend at all to do this. The third line of treatment is the pars plana vitrectomy. Pars plana vitrectomy is usually 20 for these cases because of the instrumentation. You can hold the lens well and like this, because the 23 gauge vitrectomy and 25 instruments are very delicate, and if you can try to hold the lens and like this, it's slightly difficult than 20, but it can be 23. First of all, we will separate the posterior hyaloid, then core vitrectomy plus shaving of the vitreous base if the lens or the haptic of the lens is stuck there, to release the haptic, and try always to be careful to avoid the retinal tear and retinal dialysis. Then we will grab the distal haptic with forceps, then bring the proximal one anterior to the iris. Then you will use a secondary instrument, it could be the light pipe, and push the haptic up to bring it in the anterior chamber. So whole the IOL will become in the anterior chamber as we see in this picture. Don't use the aspiration to lift the IOL from the retina, because it will fall down and maybe it will make a retinal hemorrhage or any retinal complications, retinal trauma and like this. There is a controversy for a use of perfluorocarbon liquid in the removal of dislocated IOL. Some people told it's no need to use because it's expensive, there is no advantage for it, and there is a risk of complications, especially if there is retained some retinal PFC at the vitreous base. And some others prefer to use because they told it's more safe, even while you are holding the IOL up. If it fall, it will not make a direct trauma to the retina. It will decrease the trauma with the perfluorocarbon. For me, I prefer to do it. I always do it without perfluorocarbon. What is the advantage of pars plana vitrectomy? This is the removal of dislocated IOL, avoid retinal complication, and improve the visual outcome. What is the disadvantage? There is post-operative retinal detachment. It was before common from 3 to 14%, but now with the advancement of the vitrectomy machines, it become too much less. The other disadvantage of pars plana vitrectomy is cystoid macular edema. What we will do after vitrectomy and removal of the dislocated IOL? We have some options. The first option is to place the IOL in the sulcus, in the anterior capsule, if there is a good rim. But if there is no, or you are doubt, don't put it in the anterior capsule, because maybe it will dislocate it again. And if the dislocated IOL is a flexible one, try to change it with another IOL with a rigid haptics. But there is a still of recurrent dislocation. If there is no or inadequate capsular support, the anterior chamber IOL, there is a regular anterior chamber IOL with its complication, risk of complication like uveitis, glaucoma, corneal decompensation. There is an iris fixating IOL, the Artisan. This is my favorite lens in the secondary implantation. And also there is a scleral fixation IOL, which is good also. This video, we will show a case. There is a dislocated IOL with the whole compartment, as we told before. There is a dislocation of the intraocular lens with the capsular tension ring and the back. Now I am doing anterior vitrectomy. I am using here 20. There is some cases I am using 23. According to the case, if I see the lens is not rigid haptics or like this, I can use the 23. Now you must clean very well the anterior vitreous, because there is a vitreous strands in the anterior chamber. Then, as we see, this is IOL, the whole compartment. the bag with the IOL and capsular tension ring. Now we are cleaning the vitreous, making core vitrectomy. You must make core vitrectomy all around, and also you must take care from any retinal complications. If the haptic or the IOL is not in the periphery, no need to make shaving for the vitreous base to avoid any unneeded complications. Now we clean the vitreous all around. Then with the forceps, you will hold the distal end of the haptic, as we see here. But careful, you see here the IOL is in a very difficult place over the macula. Yes. Now, and you will tilt to bring the other haptic inside. Now we are using the second instrument to hold the lens in the anterior chamber. You must be sure that the whole lens inside. And then we open the corneal incision to remove the lens. Now injecting viscoelastic above and under the IOL to protect the cornea. Now we are using the forceps now. Take it outside. As we see, hold the lens with the capsular tension ring and the bag. As we see, this is a capsular tension ring alone. Then this is the lens. This patient was a monocular patient. This is his only seeing eye. And then I will implant iris fixating artisan IOL. Then you must have a look again after you implant the IOL. If there is anything, you must clean more, and you look for the peripheral retina or any, if you see anything, so you can manage. Then we close and everything is okay. And the post-operative vision was 20/25. What's the home message of this? Be sure always before IOL implantation that there is a good and adequate capsular support. Better to implant on the anterior capsule if the bag is not well supported or there is a tear in the bag, better than you have a dislocated IOL. Better to implant anterior chamber IOL, iris fixating or scleral fixation IOL, than to have early or late dislocated IOL. Thank you.